10 minutes.
On behalf of the Northeast region, the judges would like to present to you Hamara, Al-Qatar, and Michael Judson, the regional winners.
Thank you, everyone. We are the Frozen Ambassadors. It's really cold up here, but we did not get snowed out. And this is our presentation from today's facility challenge. Okay, so the top 7 strategies that we chose were what we thought were most effective after we ran a few simulations were enabling healthy behaviors, the student and family pathways. We learned that they feed off of each other really well rather than pairing one with the other. And then support self-care. Coordinating care, those we also discovered work really well together. And then we used 2 of the funding methodologies that were the global payment and the reinvesting of savings. We noticed that one without the other also made you run out of money about 5 years in, and that does not work out very well. So this is how we structured our simulation. So we started off with enabling healthy behaviors and coordinating care. Both started in 2015 with 100% effort on both with the adjustment for new technology. Then, after playing around with it a little bit, we noticed that if we push back a few things to start off later in the day, or later in the years, it starts off with a better funding track. So we started with creating the student pathway advantages to start off the next year in 2016. And then, since that takes about 5 years to go into full implement, we decided to pair with the family pathways about 4 years later. So since that takes about a year to involve as well, the student and the family will kick off at the same time, making sure that it takes advantage of every single person in this demographic so that they're all effective. So our main goal was to focus on social aspects as much as possible and do sort of an indirect influence on policy. And so our goal was to take the disadvantaged youth and the disadvantaged population, move them out of the disadvantaged, and then while maintaining what it would be like for the advantaged population to have the best access to policy. And then we had the savings funds that were at 100% for each, reinvesting savings, and we changed the commercial savings plans to 50%. And so this is what we ended up with. So we started off with death rate being lowered, overall health per capita was lowered, our readmission rate was a lot less, our inpatient stays were less, and so taking people to go home for cares rather than staying in the hospital, which takes a hefty cost on everyone. And then our productivity, we noticed, went up, and so workplace productivity was really helpful, and disadvantaged groups went down drastically, so that was a good thing, and deaths for the disadvantaged also went down. So this was our failed attempt growth in between things. This is all the key places where we learned what a new indication was, and so we started off with our initial one where it was pretty bad, as you can tell. And then we moved up to, started naming them after things that we changed. So when we moved things out of poverty, whenever we pushed for coordination to be pushed back a year, and then when we pushed things into staggered mode, and then finally we came up with our final one, which we discovered had about pretty even impact across the board of the 5 issues, so that was really helpful. And productivity shot up over 100%, so that was really nice. And our $3.37 billion was actually nothing compared to our total costs. That halfway through, we just ignored cost and said, how many more things could we throw in efficiently, because our grant money took over, our savings took over, our investments took over, that finances were not an issue. So also a good thing. So we actually decided not to change our policy for the 3rd task rather from the 2nd task, because whenever we tried, which are the 5 simulations that you see here, we noticed that it just had a lot of negative implications all around rather than trying to take care of one stakeholder over the other or trying to sacrifice overall care. So it really just brought us back into the negatives, which we did not want to do. So we ended up staying with the thing that we had. And if we noticed here, we compared the main things from the best simulator that we had for the impact plus our own. We noticed while there was a little bit of saving up front for the main hospitals, as you all noticed was the tough one to please, it was in the short term they had a lot better of a profit, but in the long term they ended up making more money, so it was an overall better benefit to stay with our current plan. And then we went and picked a few from the stakeholders, and we gave examples of what they would be.
The first stakeholder was Harry Hospital, and Harry was probably the most upset out of all our stakeholders. And what we explained to Harry is that even though he's not seeing the profits to the baseline, he's still operating with a positive cash flow and a viable business model. And we also explained that with the new programs putting in place, there's 80% hospitals being used and 20% vacant, which could be used to shift business ideas and business practices to another aspect. The businessmen were the second stakeholder we looked at, who would be very happy, because not only did the worker care costs for healthcare costs drop drastically, but the efficiency of the healthcare of the employees also went up, because they less time off of work and more time at work instead of being sick and the chronic illness went down drastically. The insurance companies, again, it was a positive effect on them, but you see with the readmission rate, this is positive for the insurance companies. They're not paying to have people readmitted, yet this is negative for the hospital. So this is where we balanced. When we looked at task 2 to task 3, we balanced that we could make the hospital more sustainable, but in turn we're going to make people sick. So we chose the second option of making the people healthy, and the hospital kind of forced their hand to change their business model. The director of Alliance for Healthy Upstate Region was very concerned with high-risk behavior, the undereducated population, and disadvantaged population. So what our whole model that we modeled was not even to look at healthcare per se, but to look at the underlying aspects of the healthcare. So we focused mainly on society's problems with high-risk behavior and the education and the family structure. And in turn, you see the high-risk behavior drop drastically, which made another stakeholder happy. And the same thing with the social worker, with the physical illness of the uninsured, and it was the same exact concept with, like I said before, we've got the alligator mouth, where it just, as people get healthy, the cost of everything drop, and we stayed well below our baseline on all of our models, yeah. The doctors, this was another, I would say negative, because the PCPs actually increased their salary by 12%, but the specialists decreased their salary by 15%. So we actually had talked about the specialists are going to, like the hospitals, change their business model, and whether do more PCP work or coordinate with the hospital to cut costs, but we couldn't sacrifice the health of the whole population to bring the pay of the specialists back up.
So some of the trade-offs that we had that we spoke about earlier was overall patient health versus reduced need for specialty care versus sustaining our hospitals, the short-term versus the long-term, and sustainability funding. So taking all of these things into account, first we wanted to focus on how much could we influence in the short term while trying to make it cost as least as possible. So that's when we tried our initial thing of just pour funding into making healthcare better in general and then seeing what happened. So we realized that was not good. So what we did was we focused into making things into a societal focus. So we wanted to take disadvantaged youth out from being disadvantaged. We wanted to concentrate on youth, on families, and then we had sort of an indirect influence on healthcare policy in itself. You reduce risky behavior, it makes them less likely to get sick. You fix the chronic illness issues, they're more productive at work. And so in the long term, we noticed that while there was a lot of upfront costs for them, by staggering a few things, it actually ended up all paying for itself. And even stakeholders that happened to lose a little bit in the short term happened to gain in the long term, which really helped balance things off. So, and like we said, for our implementation, financing the initiatives, we had a lot of savings. We would have pushback from industries, but like Mike said, what we would do is actually just influence the hospitals to not completely stop. They're existing, they're a structure, they're there. So what we can do is just change their business model. So we have them house maybe PCPs in their facilities, so that way they can still run that. They have more hospital beds in case they wanted to do research, in case they wanted funding, in case they wanted to do anything. They're still there, they're still structuring, they just change their models. So specialists can become PCPs because they have a higher salary. There's still PCPs are always needed, but it just makes it less. So. And then we just talked about our key lessons learned was there's a lot of unintended consequences, both positive and negative. So we learned from policies interacting with one another, which is why we paired family and student together, and how preventative care and healthy behaviors worked off of each other for coordinating care, and poverty and crime all sort of built up on each other, and then implementation that had to do a lot with our stakeholders. So we were trying to figure out how we can make the most efficient policy together so that we could not have one estranged policy, but bring all society together.
And with our unintended consequences, we had set up 2 scenarios. Our first scenario was only based on healthcare and not society at all. And we actually switched it up, and we ended up getting more benefit from changing to society than healthcare.
Well done, thank you.
Thank you.
Thank you.
Nice. The last